first and second class of antiarrhythmic. First, what is arrhythmia? Anyone? What is arrhythmia? Heart rate has a rate and rhythm. The abnormality of rate and rhythm of the cardiac tissues that lead to abnormal rate and rhythm, primarily higher side, that is called tachyarrhythmia, in the lower side, that is bradyarrhythmia. So from where this impulse generated? It impulse generated from the SA node. From the SA node, it go into the AV node. Through the AV node, it goes into the ventricles. In the ventricles, there are Purkinje fibers, and it is all are the electrical conductivity of the cardiac tissue. Now, when the impulse generated go into the ventricle and ventricle stimulated, then there is some mechanical stimulation, that is the produce the contractility of the LV, left ventricle, that lead to cardiac output. So why it is very important to treat arrhythmias, because if arrhythmia conducted to the left ventricle, suppose it is stimulated 130, 140 times in a minute, what will be the difficulty? What is the abnormality that lead to death of the patient? Why? It is emergency. If the left ventricle contract 130 times in a minute, there will be a fibrillation type of things. There is not adequate cardiac activity, cardiac output will be less. Even though, because in 130 contraction, that not a single contraction is able to produce adequate amount of cardiac output, and that lead to syncope and death. So for that, we reduce, in arrhythmia, we have to reduce the stimulation in the left ventricle. So from where that impulse generated from SA node, it go into the ventricle to AV node, and here the Purkinje fibers, they electrically stimulate, and after that there is a mechanical conversion of that, lead to cardiac output in left ventricle. So in case of atria, Purkinje fiber, ventricle, there are electrophysiological has 5 stages: 0, 1, 2, 3, 4. Whereas in SA node and AV node, there are only 3. That is 0, 3 and 4. There is no 1 and 2. So what are the different ions that produce this 0, 1, 2, 3 and 4? This is for atrium, ventricle, not for SA node or AV node. Influx of sodium lead to sharp rise in the phase 0. In phase 1, there is a partial repolarization due to influx of potassium, followed by a plateau phase. In the plateau phase, there is a influx of calcium, followed by a repolarization phase due to potassium efflux. And phase 4 is the resting membrane potential. So here is sodium lead to the phase 0, followed, that is influx of sodium, followed by partial repolarization due to efflux of potassium, then calcium influx lead to the plateau phase, and the repolarization is due to efflux of potassium. What is the difference between the pacemaker cell? Here there is no 1 and no 2. Another thing is that here the phase 0 is due to influx of calcium. In case of atrium, it is influx of sodium. In case of SA node, AV node, it is influx of calcium. There is no 1 and 2. It goes directly to the 3. 3 is due to the efflux of potassium. And there is a 4. In the phase 4, there are 3 things simultaneously going on: influx of sodium, influx of calcium, and efflux of potassium. And that can lead to the spontaneous automaticity. The difference of electrophysiology of myocardium and what is the difference between SA node and AV node? First one is phase 1 and phase 2 is not there, and phase 0 for the SA node, AV node, it is due to calcium influx, whereas for the atrium, ventricle, Purkinje's tissue, it is due to influx of sodium. Another thing is effective refractory period. This is the green side. It shows that the effective refractory period. That means a stimulus, if even a highest stimulus going inside this effective refractory period cannot produce a second impulse. It is effective reflection period. So for arrhythmias, the abnormality, why there will be the arrhythmia? Due to the atherosclerosis, coronary artery spasm, heart block, myocardial ischemia. Clear? Mostly these 4 are the main abnormality to produce arrhythmias. Okay, atherosclerosis and cardiac spasm is also produce other types of abnormality, that is called কি করে? Angina. What are the pathophysiology of angina? Angina হয়েছে? কি হয়েছে সিবিএস এ? পরীক্ষা হলো তো, সিলেবাসটা তো জানতে হবে। শুধু হাইপারটেনশন? অ্যাঞ্জাইনা হয়েছে। ক রকমের অ্যাঞ্জাইনা আছে? হ্যাঁ, 3 রকমের। কি? স্টেবল, আনস্টেবল, variant. Very good. What is the pathophysiology of variant angina? What are the first line drugs of angina? First line drug? Nitrates, beta blockers, and calcium channel blockers. Among these 3, which one is contraindicated or not used in variant angina? Beta blocker. Why? Huh? রিফ্লেক্স ট্যাকিকার্ডিয়া কিভাবে হয়? ভ্যারিয়েন্ট অ্যাঞ্জাইনা প্যাথোফিজিওলজি কি? ইট ইজ ডিউ টু দ্য ভ্যাসোস্প্যাজম which cannot be counteract by the beta blocker. Beta blocker in angina, how it acts? It reduce contractility, heart rate, so oxygen demand will be less. Not they are unable to increase the oxygen supply or the vasospasm thing. So the why beta blocker is contraindicated in variant angina. So atherosclerosis, coronary artery spasm, heart block, and myocardial ischemia or infarction, they are the main cause. If arrhythmia is from the, now tachyarrhythmia can be divided into the, depending upon the from where this impulse generated. If it is generated from the atrium, SA node, or AV node, it is called supraventricular. মানে ভেন্ট্রিকেলের ওপরে supraventricular arrhythmias, the origin are atrium, then AV node or SA node. Whereas the arrhythmias impulse generated from the ventricle called the ventricular arrhythmia. Supraventricular and ventricular. Which one is more dangerous to the life? Which one is more dangerous to the life? Supraventricular or ventricular? Ventricular are the more dangerous. Why? Supraventricular arrhythmias has a chance to go through the AV node, and AV node can reduce number of impulse to conduct into the ventricle. Whereas if it is impulse generated in the ventricle, they cannot be reduced. So if there is an increased number of impulse generated from the AV node, what happens? The cardiac output will be less, because if the ventricle, left ventricle contracts 130 times in a minute, they will not able to produce adequate cardiac output. So abnormal impulse generation may be automatic, and that enhance the normal activity with increased epi from the SA node, ectopic focus other than the SA node. Other than the SA node arise from the other than the SA node, it calls the ectopic focus. Ectopic focus may be in the atrium, it may be in the ventricle. Whereas there will be a triggered arrhythmia. There may be delayed repolarization or early repolarization. That also can cause triggered rhythm, cause arrhythmia. So there are two types of impulse generated arrhythmias. One is automatic rhythm, enhanced automaticity in the SA node, or ectopic focus. Whereas triggered, there may be after depolarization or early depolarization or delayed depolarization. These are abnormal impulse generation. Next one is abnormal conduction. Abnormal conduction can be conduction block, first degree, second degree, third degree block, or there may be re-entry phenomena. In re-entry phenomena, first degree, second degree, third degree block lead to bradycardia or tachycardia. Block থাকলে first degree, second degree, third degree block হলে কি হবে? Bradycardia হবে না tachycardia হবে? হ্যাঁ? Bradycardia. And they can helpful sometime. Why? If a impulse generated from the atrium or SA node is 200 times in a minute, first degree or second degree block allow to reduce number of impulse to conduct in the ventricle, and that is helpful for surviving of the patient. Clear? Next is the re-entry. The re-entry can be circus movement or reflection. There are two types of, and they both are produce tachyarrhythmia. WPW syndrome is one of the example of it. So impulse generation and conduction both can lead to produce arrhythmias. In case of impulse generation, there may be triggered or automatic. In the automatic, there is an enhanced automaticity, or from the ectopic focus. Impulse of increased automaticity মানে কি SA node থেকেই হচ্ছে কিন্তু higher rate. Ectopic focus মানে other than SA node. It may be from the atrium, ventricle, even from the AV node. Other than the SA node, there is ectopic focus. Then there is a triggered one. Triggered one can be early or delayed after depolarization. Depolarization হয়ে যাওয়ার পর early কখনো হতে পারে, বা delayed depolarization can lead to abnormal impulse generation, that is triggered one. Whereas in the abnormal conduction, there are two types. One is block, first degree, second degree, third degree block, and another one is re-entry phenomena. It is reflection and circus type of movement. In this case, re-entry example is WPW syndrome. Accessory pathway can lead to re-excitation and lead to WPW syndrome. Now, action of the drug. How the drug can control the arrhythmia. There are two types of target. One is reduce the impulse number, মানে heart rate reduce করা, আর regularize the rhythm. There are two targets. Regularize the rhythm, and another thing is normalize the heart rate. The primary objective is normalize the heart rate. In case of abnormal generation, there are two pathology can be counteract. In case of abnormal conduction, reduced velocity, that is by the effect on the phase 0. Another is increase the effective refractory period. These two is more effective to control the arrhythmia which is due to the abnormal conduction. Clear এই পর্যন্ত? কেন অ্যারিথমিয়া হচ্ছে? অ্যারিথমিয়া কেন হচ্ছে? ওয়ান ইজ জেনারেশন, ওয়ান ইজ কন্ডাকশন। জেনারেশনের মধ্যে দু রকমের, আর কন্ডাকশনের মধ্যে দু রকমের। In case of generation, we use the drug that helpful for decrease the phase 4 slope or increase the resting membrane potential. Whereas in case of conduction, we reduce the conduction by effect on the phase 0. Phase 0. And another thing is increase the effective refractory period. Effective refractory period. Now, different types of arrhythmia. First is sinus tachycardia. Sinus tachycardia means the generation of impulse from the SA node, but in a higher rate. In a higher rate. That is sinus tachycardia. Atrial tachycardia. What is the difference between sinus tachycardia and atrial tachycardia? In sinus tachycardia, all impulse generated from the SA node. In case of atrial tachycardia, there are generation of impulse from the atrium other than the SA node. Other than the SA node. And 3 or more consecutive atrial premature beats with a heart rate of more than 110 per minute. That is atrial tachycardia. How can we distinguish between these two? Morphology P is normal in case of sinus tachycardia. But as this P is different morphology because it is generated from the atrium other than the SA node. Next is paroxysmal atrial tachycardia. Here also this is the atrial tachycardia, but it appears suddenly, paroxysmal, acute onset. Then atrial flutter and atrial fibrillation. Atrial flutter, its heart rate is 250 to 300 per minute and they produce a sawtooth appearance in ECG. Whereas atrial fibrillation, there is the uncoordinated atrial depolarization where P will be absent in the ECG. P is maybe absent in the ECG. Atrial flutter and atrial fibrillation. Then conduction block, AV block. There is a block when the impulse go through the AV node. That it is helpful for generation of, if there is a atrial flutter, impulse generated is 250 per minute, but only AV node can survive the patient due to the blockage of 2:1. So in each impulse generation, 2 impulse generation, 1 will be conducted in the ventricle. So only 125 will be conducted and producing this contraction in the ventricle. That can lead to a good enough cardiac output. But if it is 250, all are transmitted in the ventricle, what happens? The ventricle will be like a fibrillation. There is no adequate cardiac output, lead to syncope and death for the patient. Then ventricular premature beat, there the ectopic focus is in the ventricle, and that how we can see that the difference between sinus arrhythmia and ventricular arrhythmia, the QRS will be narrow and sharp for the sinus arrhythmia. For ventricle arrhythmia, QRS will be wide. QRS will be wide. Ventricular tachycardia is due to generation from the ventricle as well as transmission, and it is also a wide QRS. The complex QRS will be wide. For ventricular tachycardia, premature beat, ventricular flutter, where The ventricle is contract 200 times, more than 200 times per minute. And uncoordinated ventricular depolarization lead to fibrillation. Ventricular flutter, fibrillation, ventricular tachycardia, all are medical emergencies. All are medical emergencies. It doesn't give, which one gives more time, atrial tachycardias or ventricular tachycardias? Which one will give more time to treat the patient? Atrial tachycardia, because atrial tachycardia, atrial arrhythmias, impulse, even if impulse generation is 300, it has to come through the AV node, and there may be AV delay that lead to reduced number of impulse to reach the ventricle. And if the ventricle stimulates in 120 per minute, there may be good enough cardiac output. But if the ventricular tachycardia is 200, there will be unable to produce sustained amount of cardiac output. Pharmacological rationality and goal for arrhythmias. First one is rhythm and conduction abnormality to restore to the normal. Next one, prevent serious and possible lethal arrhythmias from occurring. That means, if there is a atrial flutter, if we try to reduce conduction to the ventricle so that there should not be any ventricular arrhythmia. There should not be any ventricular arrhythmia. That may be another goal. Decrease conduction velocity, change or duration of the effective refractory period, suppress the automaticity. These three are more focused target for the antiarrhythmic drugs. If we classify antiarrhythmia and antiarrhythmic drugs, there are 4 classes. Class 1 is due to the sodium channel blockage. Sodium channel blockage. Class 2 is beta blocker. Class 3 it is potassium channel blocker. And calcium channel blockers are the 4. At least in the classification, you have to remember class 1 is sodium channel. Class 2 beta blocker, 2 for beta. 3 for potassium and 4 for calcium, and all these are blockers. Sodium channel blocker, beta blocker, class 2, class 3, potassium channel blocker, and calcium channel blocker is the class 4. Now name some calcium channel blocker. What are the different calcium channel blockers? Amlodipine, verapamil, and diltiazem. Among these 3, which one should have an antiarrhythmic effect? Verapamil or diltiazem. Nifedipine doesn't have it acts peripherally. So antiarrhythmic, name some antiarrhythmic calcium channel blocker 4 লিখে কেউ যদি নিফেডিপিন লেখে তাহলে কিন্তু ওটা মাইনাস মার্কিং হবে। বুঝতে পেরেছো? এমসিকিউ তে which one is antiarrhythmic class 4, যদি নিফেডিপিন, অ্যামলোডিপিন তার সাথে ডিলটিয়াজিম থাকে তাহলে ডিলটিয়াজিম, ভেরাপামিল থাকলে ভেরাপামিলটা দিতে হবে। ক্লিয়ার? বিটা ব্লকারে কি হবে? কোন কোন বিটা ব্লকার হতে পারে? বোথ সিলেক্টিভ এন্ড নন সিলেক্টিভ। প্রোপানল and another one is esmolol, metoprolol. All can have a antiarrhythmic. Now another catch is that another drug name is sotalol. You heard the drug name sotalol? Sotalol is a is a beta blocker. Though it is a beta blocker, for its action is primarily classified into the class 3. Though they are a beta blocker, so MCQ class 3 beta blocker, class 3 antiarrhythmic, esmolol, propanolol, sotalol, আর তার সাথে মেটোপ্রোলল থাকলে কোনটা দিতে হবে? Sotalol. Sotalol, though it is a beta blocker, it comes under the class 3. Class 3. Now sodium channel blocker or class 1, they have a 3 subclass: 1A, 1B, 1C. How they act? They open the sodium channel in inactivated or inactivated state. So they reduce the conduction velocity of the non-nodal. Non-nodal means other than SA node and AV node, atrium, ventricle, Purkinje tissue. So they are used when there is a tachycardia. When there is a tachycardia, তাহলে sodium channel in inactive state they primarily help when there is a effective tachycardia by reducing the conduction of atrium, ventricle and Purkinje tissue, not in the SA node or AV node. How they act? Mechanism of action: phase 0, slow rise of phase 0 that reduce to conduction velocity. Vmax will be less. There is a increase, prolong the effective refractory period in ventricle. Effective refractory period. And fourth one, the slope of phase 4 will be reduced. তাহলে phase দুটো ফেজের উপর effective, more effective. One is phase 0 and phase 4. দুটোতেই কি করছে? Conduction velocity কমাচ্ছে স্লো করে phase 0. Similarly phase 4 করে automaticity কমাচ্ছে। 0 আর 4 এর উপর কাজ আছে। কিভাবে কাজ করছে 0 আর 4 এ? সোডিয়াম চ্যানেলকে ব্লক করে when there is a tachycardia. Other than that, Vmax will be less, as well as there should be a effective refractory period will be increased. এগুলো সব কোথায় হচ্ছে? SA node, AV node হচ্ছে। সোডিয়াম চ্যানেলে কি SA node, AV node এর উপর কোনো কাজ আছে? ক্যালসিয়াম primarily, then potassium, then all three in the stage 4. All these are in the atrium, ventricle, Purkinje tissue, where phase 0 is conducted due to sodium channel influx. সেখানে কি করছে? They reduce the slope of the phase 0, reduce the Vmax, increase the effective refractory period, and reduce the slope of the phase 4 also. Clear? এই চারটে পয়েন্ট। phase 1, phase 4 effective refractory period বাড়াবে, effective refractory period বাড়ালো। আর কি করছে? they reduce the Vmax. কোথায় কাজ করছে এরা? সোডিয়াম চ্যানেলে। সোডিয়াম চ্যানেলটা এফেক্টিভ কোথায়? other than SA node, AV node. Other than SA node, তার মানে কি? ventricle, atrium, Purkinje tissue. Conduction will be less. Clear? Mechanism of class 1. There are subtype A, B, C. For A, procainamide and quinidine. Procainamide and quinidine both have a very good bioavailability. নাম দুটো মনে রাখতে হবে। procainamide, quinidine. Procainamide IV to avoid hypotension. কেন হাইপোটেনশনের জন্য IV দিচ্ছি? We can control it, titrate it, but in case of oral drug we cannot titrate the drug. So for control the hypotension we can give titration through the IV for procainamide. But both procainamide and quinidine, which is a class 1A drug, effective by blocking sodium channel, is used for tachyarrhythmias by controlling the conduction through the atrium and ventricle and Parkinsonism. কোথায় ইউজ হয়? It can be used both supraventricular and ventricular, but primarily quinidine is rarely used in supraventricular. Oral quinidine and procainamide used along with class 3. Class 3 ki? Potassium channel blocker. Now name a potassium channel opener. Where it is used? Nicorandin কোথায়? Angina. Very good. You have to remember it is a potassium channel blocker at the antiarrhythmic class 3. Name is amiodarone. Name is sotalol. These are the class 3. Class 1A quinidine, procainamide. Primarily used in ventricular. Some role in the supraventricular also. In case of refractory ventricular arrhythmia, quinidine and procainamide along with class 3 can be used. IV procainamide used for hemodynamically stable, not unstable, hemodynamically stable type of ventricular tachyarrhythmia. If ventricularly hemodynamically unstable, most of the arrhythmia, the treatment of choice is DC cardioversion. IV procainamide used in WPW syndrome. Clear? কোথায় ইউজ হচ্ছে? ক্লাস 1A, নাম কি? প্রোকেনামাইড কুইনিডিন। কোথায় ইউজ হচ্ছে? প্রাইমারিলি ভেন্ট্রিকুলার অ্যারিথমিয়াস along in case of resistance along with 3, in case of WPWB procainamide and hemodynamically stable ventricular tachycardia. So toxicity, quinidine can cause AV block, torsade point, shortens the AV refractoriness, increase digoxin concentration. Digoxin কোথায় ইউজ হয় এখন? ডিগক্সিন পড়ানো হয়েছে? ডিগক্সিন কোথায়? জোরে কোথায়? জোরে জোরে বলো না, ভয় পাচ্ছ কেন? ওদের কি বলবো? পরীক্ষা তো দিয়ে এলে কালকে, বলো কোথায় ইউজ হয় ডিগক্সিন? কিডনি? কিডনি কি? জোরে বলো, একটু শুনতে পাচ্ছি না বাবা, একেবারে শুনতে পাচ্ছি না। ইউরিন কনসেন্ট্রেশন, ডিগক্সিন বলে না, ডায়ুরেটিক বলে। ডিগক্সিন কোথায় ইউজ হয়? ডিগক্সিন পজিটিভ আয়োনোট্রপিক। কোথায় ক্লিনিক্যাল ইউজটা বলো? হার্টে তো 4-5টা জিনিস আছে, কোথায় কোথায় ক্লিনিক্যাল? হাইপারটেনশনে ইউজ হয়, অ্যানজাইনা ইউজ হয়, অ্যারিথমিয়া ইউজ হয়, হার্ট ফেলিওরে ইউজ হয় না? কোনটা কোনটা ইউজ হয়? হার্ট ফেলিওরে। ট্রিটমেন্ট অফ চয়েস, now it restricted to the AF, atrial fibrillation with heart failure. It commonly used in heart failure in pediatric age group also, but rarely used as a first line drug. First line drug ki congestive cardiac failure? First line drug? Furosemide. First line drug. পালমোনারি ইডিমায় কি ড্রাগ ইউজ হয়? লেফট ভেন্ট্রিকুলার ফেলিওর, পালমোনারি ইডিমা এক না আলাদা? কি ড্রাগ দেয় তাতে? ফুরোসেমাইড। It is which group of drug it is? High ceiling diuretics. It shifts the blood from the pulmonary circuit to the systemic circuit, reduce the respiratory syndrome. Drug of choice for hypertension ki? First line hypertensive, ACED inhibitor, ARBs, CCB, thiazide. Beta blocker is a first line drug in hypertension. It is not a first line drug. First line drug for heart failure is high ceiling diuretics. High ceiling diuretics is not a first line drug of hypertension. For hypertension, diuretics is a first line drug, but that is thiazide. Clear? Similarly, quinidine can increase digoxin concentration and that can lead to digoxin toxicities. Similarly, it can lead to all the antiarrhythmic has a property of proarrhythmic in different electrolyte and clinical situation. Whereas procainamide can lead to asystole or ventricular arrhythmia. Asystole or ventricular arrhythmia. There is also hypersensitivity and agranulocytosis. There is another term, drug induced SLE. SLE full form is systemic lupus erythematosus. Some drug can produce this type of symptom. Procainamide is one of the drug that can produce SLE like symptom. SLE te ki symptom niye asbe patient? Butterfly rashes or joint pain. There may be some ascites or inflammation of the intra-abdominal organs. That can be the kidney damage that can be produced by some drug induced SLE. Clear? By procainamide. This is the ECG of Torsady point that can produce by quinidine. Quinidine can causes synchronism. In synchronism, there is a blurring of vision, tinnitus. Tinnitus ta ki? What is tinnitus? Eta bhobo awaz hobe kane kache. Headache, psychosis, gastrointestinal upset. This is due to high dose of quinidine. Clear? ECG টা দেখে রাখো, অনেক সময় MCQ তে আসে। Which drug can produce this type of ECG? কে করে? Quinidine. যদি quinidine ডাইরেক্ট না দিয়ে এরকমও দিতে পারে, ক্লাস 1A, 1B, 1C, ক্লাস 4 কি হবে? 1A. Class B is lignocaine. Its congeners like mexilidine and tocentinide. These are the class 1B. Their effect is in the phase 3 repolarization. Phase 3 repolarization reduce cardiac action potential, rapid association and dissociation, whereas dissociation is a weak effect with no effect of conduction velocity. Another thing, conduction velocity te kar kono effect nei. 1B ড্রাগ কি? 1 নম্বর ড্রাগটা মনে রাখবে, তাহলে বাকিগুলো মনে থাকবে। Lignocaine is the class 1B. They have no effect on the conduction velocity. কোথায় এফেক্ট আছে তাহলে? ফেজ 3 তে। 1A তে কোথায় ছিল? ফেজ 0 and phase 4A. For class 1B it is phase 3. Name of the drug is lignocaine. At least remember lignocaine. IV lignocaine extensive. Why it is used? Because extensive fast pulse metabolism when used orally. Whereas oral analog of lignocaine is mexiletine. It is the oral analog. Adverse effects are neurological, negative ionotropic effect. Oral congener of lignocaine, mexiletine. কোথায় কাজ করে? phase 3. কোথায় কাজ করে না? conduction velocity তে। Class is 1B. 1C, flecainide, propofenone. markedly slow the phase 0. Phase 0 আগে কে কাজ করেছে? 1A, quinidine, procainamide. They markedly slow the conduction. Conduction এর উপর কোনো কাজ নেই। 1B, lignocaine maxillate কোনো কাজ নেই। Conduction is markedly slowed by 1C. Phase 0 is slowed by 1C. Slow rate of association and dissociation, where dissociation is a strong effect. This effect is present also in a 1B, but is a weaker effect. But for 1C, it is a very strong effect. Then they only have a minor effect of duration of the action potential. Duration of the effective action potential এ কার সবচেয়ে ABC এর মধ্যে সবচেয়ে বেশি এফেক্ট কার? 1A. Minor effect of duration of action potential and refractoriness for 1C. Maximum তাহলে কার আছে? 1A. 1A ড্রাগের নাম কি? প্রোকেনামাইড, কুইনিডিন। 1B কি নাম? লিগনোকেন, ওরাল কনজেনার, ম্যাক্সিটিটিন। সি এর কি নাম? ফ্লেকানাইড, প্রোপোফেন। ফ্লেকানাইড, প্রোপোফেন কোথায় কাজ করে? ফেজ 0 কন্ডাকশন, লেস in the effective refractory period. They reduce the automaticity by increasing the threshold potential rather than decrease the slope of phase 0 and phase 4 spontaneous depolarization. Here this is the difference from the phase 1C from the 1A. 1A thresholdটাকে decreasing slope দিয়ে করে। ড্রাগের নামগুলো অন্তত মনে রাখতে পারবে তো? 1A, 1B, 1C। 1A তে কে? কুইনিডিন, প্রোকেনামাইড। 1B, লিগনোকেন। 1C, প্রোপোফেনন, ফ্লেকানাইড। কোথায় ইউজ হয়? রিফ্র্যাক্টরি ভেন্ট্রিকুলার অ্যারিথমিয়াস। দেন ফ্লেকানাইড particularly potent suppression of premature ventricular contraction. Toxicity: 1C is a very pro-arrhythmogenic drug. Severe worsening of pre-existing arrhythmia, তার মানে যেটা স্পেসিফিক সেটা ছাড়া বা যেগুলো রেজিস্ট্যান্ট ভেন্ট্রিকুলার অ্যারিথমিয়া ছাড়া এগুলো ফার্স্ট লাইন ড্রাগ হিসেবে ইউজ করা হয় না। ডি নোভো অকারেন্স অফ লাইফ থ্রেটেনিং ভেন্ট্রিকুলার ট্যাকিকার্ডিয়া। Patient with frequent premature contraction following myocardial infarction, flecainide increase mortality. তাহলে এখানে কি দেবে? MI followed by ventricular ectopics, beta blocker is used. If we give 1C flecainide, they can increase mortality. Clear? The 1C is a very good reserve antiarrhythmic. For MCQs, sodium channel blockage most in the 1C followed by 1A, then followed by 1B. In case of increased EPR, it is 1A followed by 1B, 1C followed by 1B. তার মানে দুটো ক্ষেত্রে 1B is the least one. Sodium channel are effective refractory period. বিটা ব্লকার পড়াবো না পরের দিনের জন্য ছেড়ে দেব? বিটা ব্লকারটা করে ছেড়ে দিই, ছোট একদম। কি করবে নাকি পুরোটাই পড়ে? হ্যাঁ, একটুখানি পড়িয়ে দিন। বিটা ব্লকার খুব সোজা, দুটো স্লাইড শুধু, এগুলো সব জানো সেই জন্য আমি বলছি। বিটা ব্লকার কিভাবে কাজ করে? অ্যান্টিঅ্যারিথমিক, বিটা ব্লকার অ্যাজ অ্যান্টিঅ্যারিথমিক কোন রিসেপ্টর ব্লক করবে? সব জানো তোমরা, দেখো কোন বিটা 1 না বিটা 2? বিটা 1। তো ইট ব্লকস দ্য বিটা 1, রিডিউস আয়োনোট্রপিক, ক্রোনোট্রপিক, ব্রোমোট্রপিক, বাথমোট্রপিক এফেক্ট, তাই তো? কোথায় ব্লক করে? বিটা 1। প্রলং এভি কন্ডাকশন, এটাও তোমরা জানো, ব্রোমোট্রপিক, বাথমোট্রপিক এফেক্ট হলে। ডিমিনিশ ফেজ 4 ডিপোলারাইজেশন, সাপ্রেসিং দ্য অটোমেটিসিটি। তার মানে ওই যে চারটে কথা আছে সবকটাই এটাই ঘুরিয়ে ফিরিয়ে বলা। অটোমেটিসিটি কমাচ্ছে, এভি নোডের কন্ডাকশন কমাচ্ছে, আয়োনোট্রপিক, কোনোট্রপিক অ্যাকশন। তাহলে কোথায় ইউজ হয়? ইনক্রিজ হয় সিম্প্যাথেটিক অ্যাক্টিভিটি ইনডিউস ট্যাকিকার্ডিয়া, স্ট্রেস ইনডিউস, এক্সারসাইজ ইনডিউস অ্যারিথমিয়াস। হিয়ার ইট ইজ ভেরি গুড। নাও অ্যাট্রিয়াল ফ্লাটার অ্যান্ড ফিব্রিলেশন। তাহলে আমরা ওয়ানে কি দেখেছি? ওয়ানে অ্যাট্রিয়াল দেখলাম না ভেন্ট্রিকেল দেখলাম? প্রাইমারিলি ভেন্ট্রিকুলার অ্যারিথমিয়া, তাই তো? 1A 1B 1C। তাহলে অ্যাট্রিয়াল কোথায় দেখবো? অ্যাট্রিয়াল ফ্লাটার, অ্যাট্রিয়াল ফিব্রিলেশনে বিটা ব্লকার। রিডিউস মর্টালিটি ইন পোস্ট মায়োকার্ডিয়াল ইনফাকশন পেশেন্ট। কি দিলে বেশি হয়? ফ্লেকানাইট দিলে, 1C দিলে। কোথায় তাহলে কি দেব? মায়োকার্ডিয়াল ইনফাকশনের পরে বিটা ব্লকার কেন দিই? ইনফেকশনে বিটা ব্লকার কেন দিই? একটা তো রিমডেলিং, মনে আছে? রিমডেলিং, প্রিভেনশন অফ রিমডেলিং, রিডিউস মর্টালিটি ডিউ টু counteract the arrhythmias, both ventricular and supraventricular. Protection against the sudden cardiac death. Beta blockers are effective in atrial fibrillation, flutter, post-myocardial arrhythmias as well as the cardiac death. কিভাবে কাজ করে? It blocks the beta 1 and reduce, কি reduce করে? Inotropic, chronotropic, bromotropic, bathmotropic effects. All four are reduced. Propranolol is a non-selective one. Metoprolol is a selective one. Esmolol is an important thing. Esmolol, why it is important? It is one of very few. It is only the beta blocker that can be given, selective beta blocker that can be given intravenously. আর কি দেওয়া যায়? লেভোটরল দেওয়া যায়, লেভোটরল দেওয়া, কিন্তু ইট ইজ নট এ কার্ডিওসিলেক্টিভ। লেভোটরল কোথায় দেওয়া হয়? লেভোটরল হাইপারটেনসিভ এমার্জেন্সি আর প্রেগনেন্সি ইনডিউস এমার্জেন্সিতে। বিটা ব্লকার, it has a beta blocker effect along with a alpha blocker, a third generation, but it is not a cardiac specific. You have to remember the only cardiac specific beta blocker that can be given intravenously is esmolol, that can be used as an antiarrhythmic.